So let's go ahead and review some of the information that we did go over last week, just the last couple of slides. We had just started talking about mania and saw a brief video clip. So we also went over the manic episode criteria that involves having at least 3 symptoms for a period of a week, and then having one of the following also has to occur. Now for a hypomanic episode, and this should also be reviewed in addition, you have to have at least 3 of those symptoms for only a period of 4 days, so fewer amounts of time. And those symptoms are not enough to cause impairment in functioning, a hospitalization, or a threat to harm to someone else. So a hypomanic episode tends to be less severe than the regular manic episodes. So let's go ahead and move on to talking about the types of manic disorders we know, because when we sense that a client has mania, we just have to figure out and decide what type of mania they have. So the first one is we can diagnose straight mania. Now that's actually very uncommon that a person has mania and no depressive symptoms, but occasionally it happens. What we more commonly are going to diagnose is bipolar 1 and bipolar 2. So bipolar 1 disorder, usually the disorder begins, it involves mania accompanied by major depression. So all of the symptoms of major depression that we talked about would hold for this bipolar 1 disorder. And we know that bipolar 1 disorder often begins in late adolescence, so oftentimes late teens, early 20s, and it usually will begin with a manic episode. So a person very commonly won't have any history of depressive symptoms, but then they will develop this manic episode, and that's a clue that perhaps bipolar is going on. Other types of bipolar disorders we'll talk about in a minute, but I wanted to go ahead and link this. Whoops. Sorry, I'm just getting adjusted to all this. I wanted to go ahead and link this video that does a pretty good job describing the types of bipolar disorders. It's about 5 minutes. With this YouTube video, I don't know that you're going to be able to click to it from this video, but you can at least type in or copy and paste. And I also am going to have an unrecorded version of this PowerPoint slide in the Blackboard site under unrecorded PowerPoints. So if you don't want to go through the hoops of retyping it in, you can just go look at that and then link directly to this video. Okay, bipolar 2 disorder, a little bit different. This involves episodes of hypomania rather than mania, accompanied by those symptoms of major depression that we talked about. And for this one, sometimes we find that when people seek treatment, it's for the depressive symptoms, not the manic symptoms. Because as we talked about in class, the lower levels of mania sometimes are okay with people. They can be very productive, they don't need as much sleep, they find that their creativity is heightened. If they don't have the irritability, sometimes they feel good. So many times people are reluctant to get treatment for bipolar 2 because they really don't want to get rid of that hypomanic effect. And then one other type of manic disorder, and this is similar to the depressive dysthymia, is when a person has what we call cyclothymia. And this is depression and mania that is less severe than it would be for bipolar 1 or bipolar 2. And there is this lower level, longer term duration. So about a 2-year duration that people have to have symptoms. And then we could diagnose cyclothymia. A few other things about bipolar, and I say etc., these are just kind of some pieces of tidbits. We find with bipolar 1 there really isn't a sex difference. It tends to accompany, there's really no gender differential with this. For bipolar 2, however, females are diagnosed more than males are. And we think that part of this might be just the social desirability aspect of seeking treatment for depression. If a person has bipolar 1, oftentimes the mania really is, and by criteria, it's interfering very much in their lives. But with bipolar 2, that might not be the case, so it might just be a severe depression for the person. So they may seek treatment, and as we've talked about, females are more likely to seek treatment for depression than males are. So that may be one explanation for that. We find that this disorder is sometimes higher among upper socioeconomic status groups. This one again is hard to understand, but it may be a treatment-seeking differential that people in higher SES groups have the means to seek treatment, and so that may be somewhat of an inflated statistic there. We know that people who are engaged in something called rapid cycling have a poorer prognosis. So about 18% of people with bipolar disorder have what we call rapid cycling, and that means they switch back and forth quickly from the manic phase to the depressed phase. So for example, in say a typical case, a person may spend several days, a couple of weeks in a depressed phase, and then a couple of weeks in a manic phase. Well, the shorter those periods of time in each phases, the poorer prognosis. So that means those folks are perhaps going to struggle more. They may have be less responsive to medication. They just may have a harder time. So of course there are exceptions to that, but that's one thing the research has found. And then we also know the median age of onset for mania or the bipolar disorders is around 25. And I know we said that the typical time is it often starts in late adolescence, but this is the median. So we occasionally will have people who are older who develop this, but in general, people are typically on the younger side. Let's go ahead and move now to talking about some of the causes of bipolar, and then we will return to major depression and talk about the causes of that. So we know, of course, as with many of the other disorders, there is a inherited cause, there is a heredity cause. A person with bipolar disorder is likely to have another family member with a mood disorder, not necessarily bipolar, but it really can be any mood disorder. Of course, we turn to twin studies. We know that the concordance rate for monozygotic twins is about 40% and dizygotic twins much lower, between 5 and 10. So what that tells us is that there is a higher genetic component to this for the identical twins than the fraternal twins. So that's something to keep in mind. And then we have this interesting phenomenon, and we'll see this also with schizophrenia, that has to do with people who have the genetic predisposition for bipolar but don't develop it themselves. So say, for example, we take a pair of twins, identical twins. This twin, the first twin, has bipolar disorder. The bi is short for bipolar disorder. Their twin, their identical twin, is healthy, does not develop bipolar disorder. And let's say they both have children. What we know is that for twin 1 or for twin 2, despite the parent not having bipolar disorder, they are just as likely to develop bipolar disorder as the child of the ill parent. So what this tells us is that people can have the genetic predisposition for this disorder, not develop it themselves, but then still pass it along to their children. That's an important biological component we know. A little bit more that we know about biological causes of bipolar disorder. The rate of diagnosis of bipolar disorder at age 21 was about 23% among kids of parents with bipolar disorder. So this was a very recent study a couple of years ago that looked at kids of parents who had bipolar disorder. So 23% is pretty high. It was only 3% in the control group. So this was the rate of bipolar disorder in kids whose parents did not have bipolar disorder. And then we also know that kids who have a parent with bipolar disorder are also more likely to have other diagnoses. For example, ADHD, oppositional defiant disorder. That's a disorder we'll talk about coming up here in the childhood disorder chapter. That involves kids who just will not obey authority, can't obey authority, tend to get in trouble a lot. And then anxiety and depression. So this very recent large-scale study shows us again the depth of the inheritability component of bipolar disorder. Now, as we've talked about, the genetics affect the brain and affect neurotransmitters. So we're not going to get too deep into the neurobiology of this, but we know that many people with bipolar disorder have low levels of serotonin combined with higher levels of norepinephrine. So that has in the past presented kind of a clinical challenge to try and find medications that treat both of those and that change both of those neurotransmitter levels, because what you don't want to do is give people tons of different medications. We try and find the smallest number of medications that affect this. So when we talk here in a bit about the medications, we'll get into that a bit more. Now, what about the role of the environment or the role of stress? This is something that's been examined, and people will sometimes ask, well, what kind of stress is strong enough that it would trigger an episode of bipolar disorder? That question is hard to answer, but we do know that stress can precipitate manic episodes in particular. So not stress like, you've got an exam tomorrow. Typically, it's something severe money problems or relationship problems, but it really can be any range, but generally some kind of stress can precipitate that. And then we also know, looking at the biology combined with the environment, that kids are more likely to develop bipolar disorder when a parent has frequent episodes. So when a parent is more involved in the faster cycling or the rapid cycling, those children would be more likely to develop that disorder. So that also tells us the role of stress. Okay, so let's talk about the treatment of bipolar disorder and how we do that. Generally, we do not use antidepressants to treat bipolar disorder. We use mood stabilizers. Now, the reason that antidepressants are not used, even though there's typically a depressive component to bipolar disorder, is that research has shown that antidepressants can actually bring on a manic episode. So say a person is experiencing depression and they've had no signs of mania, and they go to their physician and they get an antidepressant. Well, if what is really going on for that person is bipolar disorder, that antidepressant may actually trigger that manic episode. And of course, that's not something we want. The problem is when a patient comes in or a client comes in with symptoms of depression, we don't have any way to test to see whether it's really bipolar going on. So that's one of the reasons why physicians will oftentimes ask very specific, very clear questions about any instances, any hint of mania, but it may not be there. So one of the medications used to treat bipolar disorder is lithium, which tends to have gotten kind of a nasty rap, I think, in the public perception. But lithium is actually a common salt that's in really tiny amounts in our drinking water. So the lithium treats the mania and the depression. It slows down the dopamine and the norepinephrine, and then it increases the serotonin, which is something that's needed for bipolar disorder. Unfortunately, with this one, it doesn't take much of an overdose to actually create an overdose. So you have to be really careful with lithium. A couple of the other problems that go along with it is that some people experience substantial weight gain, which obviously is undesirable. Other people have tremors. The technology has evolved so that they're able to come up with better derivations to reduce some of those side effects, but it's still a problem. So the second order line of treatment, if the side effects are too much or if the lithium just isn't working, are anticonvulsants, which have typically been used for people for seizures. So a couple examples are Depakote, Lamictal. Anticonvulsants also have their side effects. They can also cause weight gain. They tend to cause drowsiness for a lot of people. So if a person still has to work, this one may be problematic. And then the third line of treatment for bipolar disorder are actually the antipsychotic medications, the medications that are used for psychotic disorders like schizophrenia. So a couple of examples are Zyprexa, Geodon, Abilify, Risperdal. Occasionally people with bipolar will take a couple of different categories of these, but they all are very strong medications. They all have side effects to them, so it may take some trial and error, but these medications really need to be prescribed very carefully. All of these medications, all these mood disorders, work by changing the activity within the receiving neuron. So if you think about the analogy that we looked at where neurons lay end to end, so the neuron that's going to be receiving the neurotransmitters from the preceding neuron, just like with depression, as we'll talk about, that's where the medications act. As I mentioned, the antidepressants alone may invoke mania, so you want to be careful about that. And really, one of the biggest things with these medications is non-compliance. As we talked about, people sometimes don't want to take the medication because they don't mind the hypomania effect. And because of the side effects from these, sometimes people just don't want to deal with that and they won't take the medication. So bipolar disorder, of all the disorders, is really one of the main ones where non-compliance is a problem with medication. All right, let's go ahead and move back to depression. And the final part of this chapter is going to talk about the causes of depression and then compatible treatments for that. In your book, and I believe this is part of the reading I assigned, they describe psychoanalytic theory as far as the cause. We generally don't look at that or rely on that anymore because the science just isn't there, but I would like you to read about it because those are historically important theories. What we do look very much to today is, first of all, cognitive theory. And we briefly talked about this at the beginning of the semester. It's the idea that irrational, illogical beliefs lead to depression. It's not events in your life, say your significant other broke up with you, it's your thinking about that and your irrational thoughts. For example, oh, no one will ever love me again. So I've linked here a pretty good video to watch. It's about 7 minutes, but it gives a really good example of the different kinds of irrational beliefs that people sometimes hold. And I'm going to explain here in a minute a couple of them, but this video is worth getting another look just to get some more examples because, as far as exams are concerned, I like examples. So just a little hint there. Here are a couple of instances of some of the irrational beliefs that people hold. First of all, there's one that we call arbitrary inference, and this is when people make conclusions from insufficient evidence. And I know I've given this example before, but the best one is, or a good one I should say, is if your friend blows you off, texts you and says, hey, I can't make it to this thing tonight, talk to you later, without really much of an explanation, and you immediately think to yourself, oh, they don't like me anymore, they're mad at me, what did I do? Well, you don't have evidence that that's what's going on, so you've really kind of jumped to conclusions. Another example is what we call selective abstraction, and this is when you focus on some insignificant detail and ignore more important details to the extent that it makes you upset. So let's say you get your report card, you get your grade, and you have, let's just say, all B's and a C+. And all you can focus on is that C+. I mean, a B is an excellent grade. And so if you're evaluating yourself as a student based on that C+, that would be selective abstraction. You're ignoring all the other more important things. The fact that you got really good grades overwhelmingly, except for that one thing. Okay, another one would be something called magnification and minimization. So this is when you blow up small things that are bad and you make smaller big things that are good. So my mom used to say to me when I was growing up, oh, you're making a mountain out of a molehill. That's blowing up a small bad event. So say in a class you have a 10-point quiz that you totally forgot about and you blew and you got like 2 or 3 points on it. And you just, oh my gosh, my grade's going to suffer. This is going to be so terrible. Well, it's 10 points. And in the average class, that's not going to matter that much. That would be what's called magnification. At the same time, you're ignoring the A you got on the exam last week. That would be minimization. That's a much larger event in most classes. So you're making that into a smaller thing. Okay, so all of that falls under cognitive theory. There are more, and the video that I just linked gives you other kinds of examples, but these are 3 of the main ones that I think are the most important and that people tend to hold in their minds most commonly. So if you use any of these, and you know what, we all do from time to time, but too much of this is going to lead to some negative feelings, including depression. Okay, a second model or explanation for depression is what we call the learned helplessness model. And I think I explained this at the beginning of the semester, but let me just give a quick review of how this works in relation to depression. We become helpless, we learn to be helpless when we perceive that what we do doesn't impact our environment at all. And of course, I think I'm not sure if I explained this model to you at all, but Martin Seligman, the man who first talked about and investigated learned helplessness, who as an aside now is the leading proponent in the psychology field of all the optimism research, so he's kind of gone from one extreme to the next, pointed out that when you put a creature in a situation that's inescapable, for example, he put, and I don't think he'd get away with this study now, but he put dogs in cages, as you can see in this picture, where side A, they delivered shock to the floor, and the dogs could jump over this barrier to side B where there was no shock, and they did that. But then they did a further series of studies where they raised that barrier. The dogs could not escape from the A. It was not enough shock to kill them, but many of those dogs later died just from the depression and the being in a bad situation. So, I mean, a really sad series of experiments that showed us that this is true for humans too. So think about a person who is in a relationship that they feel stuck in. Maybe they've got children and they're financially dependent. Or think about a person who is working a job that they can't stand, but they've got a family to support. Anytime you put a person in a situation that they can't escape, it just opens them up for depression. And then the really unfortunate thing about the learned helplessness is that hopelessness can often occur as a result of that helplessness. And as we're going to see in the next chapter, hopelessness is kind of one of the big emotions that goes along with people who are thinking about harming themselves. The next model or explanation is the learning model, and I know I also went over this a little bit at the beginning of the semester. How this tends to relate to depression is that when people are depressed, their depressed behavior becomes reinforced too much from other people, and they don't get enough reinforcement for non-depressive kinds of behavior. So let me explain. According to the learning model, oftentimes depression starts with some kind of a loss. This could be a loss of a family member, it could be a loss of a pet, a class that you failed, whatever. Well, losses naturally lead to depression. That's the typical human response. And when you are depressed and suffer a loss, you get sympathy from other people. Unfortunately, people are only going to be around, it's hard to be around a depressed person. It's hard to provide that constant sympathy. So eventually, people withdraw the sympathy, they back away, they move on to their own lives, and the depressed person loses that support. Well, then they don't even have that, and so that further ingrains the depression. And as we'll see in treatment here in a couple of minutes, what we have to do is intercept this cycle and help people learn to display behaviors that are going to be reinforced for them. All right, well, the last model here I want to talk a little bit more is the biological model. And we've mentioned this a bit already, but this model has really been around for a long time. It was in the 1960s that researchers discovered that depression may arise from disruptions in the neurotransmitter balance. And at that time, they started developing the first medications to help depression. The problem is there is no way to test this directly. We don't have a blood test, an easy blood test to look at your neurotransmitter balance. The way we look at neurotransmitters is either through taking a piece of brain tissue and analyzing it, which of course we're not going to do for people who have depression, the average person. Or we can remove some cerebral spinal fluid in what's called a spinal tap or a lumbar puncture, which is kind of a big procedure. They insert a large needle into the spinal column and withdraw fluid and analyze it. And of course, we're not going to do that for the average person with depression. So the way we handle this is just by experimenting with medication. We'll get to that in just a minute. So we know that for many people with depression, there is a depletion of norepinephrine and serotonin. It's actually not a depletion, it's a faulty transmission of norepinephrine and serotonin. So essentially, and this is really in layperson's terms, not enough norepinephrine and serotonin is getting through to the neuronal system, and that leads to the depression. So if we look at this sketch, we've seen things like this before. If we've got serotonin in the preceding neuron, in the firing neuron, and those neurotransmitters spill into the synaptic gap and then bind onto the dendrites of that postsynaptic neuron, we can see that some of the serotonin gets through, but some of it does not, and reuptake occurs, and so we have to kind of stop that reuptake transmission, and we'll get to that in just a minute. Okay, well, let's move on here and finish up with talking about treatment for depression. They're developing new therapies all the time. Depression is the #1 cause of disability worldwide. I don't know if you all knew this. I mean, really above any physical disability, but we're talking about work disability here. So coming up with new treatments all the time is really important. We'll start with one of the main ones that's used is antidepressant medication. Now, as a psychologist, sometimes I'm asked how I feel about medication since I don't treat with medication, I treat with talk therapy. And my take on it is when a person is depressed, we get all the guns out. We hit it with double barrels. We treat it however we can. Antidepressant medication changes people's lives. It saves people's lives. And I understand that some people don't want to use it. I get that, but it really is significantly helpful for a large number of people. So we have really three different categories of antidepressant medication that can be prescribed: tricyclics, MAO inhibitors, and SSRIs or SNRIs. And this is in your book, but the SSRI stands for selective serotonin reuptake inhibitors. SNRIs, selective norepinephrine and serotonin reuptake inhibitors. This is on a later slide. So let's start with I just want to give you a view of all of these. The tricyclics are an older medication, and a couple of examples are Elavil and Tofranil. You've probably never heard of these before because they're not prescribed very often. These have been around since the 1960s. We were some of the earliest ones, and they act on the reuptake of norepinephrine and serotonin. So if we can kind of slow down that reuptake process, then we can hopefully get more norepinephrine and serotonin through to the postsynaptic neuron. One of the biggest problems with these older antidepressants is that they have some side effects that are pretty significant. They are called anticholinergic effects as a group. So the anticholinergic effects is the name for the type of side effects, and they can include these things: dry mouth, which is livable for most people, but it can be pretty unpleasant, blurry vision, and a decline in sexual functioning and sexual reactivity, which is certainly distressing for some people. These medications take about 3 weeks to work. These aren't happy pills. It's not like you take them and you feel better right away. They have to build up in the system, and it takes a while to start to act on the reuptake functioning. So people have to understand that, because they may feel right away, oh, they're not working, but they take a little while. Another big problem with these is that they are what we call cardiotoxic. Overdose can be a problem. For people who are at high risk for overdose, these really shouldn't be prescribed because there is a pretty high risk to cardiac functioning with an overdose. A second category of older antidepressant medications are called MAO inhibitors. A couple of examples are Marplan and Nardil, and I will occasionally have a client who will come in who will be taking these medications. We generally start with the SSRIs, which I'll talk about in a moment, and then if those don't work, we try all of them, and then you move to the older categories. And sometimes people can't take the SSRIs for different reasons. So the thing with the MAO inhibitors that makes them really interesting, they're less often used, and they're more used for atypical depression. So for example, if people have panic symptoms, or they have increased appetite or can't sleep, kind of that category of symptoms, we may use them. So the reason, or the way that we would use them, is like this. These stop the MAO enzyme. So if you look at this chart here below, it says MAO converts dopamine to an inactive substance. So the MAO enzyme tends to degrade the neurotransmitters that we want. MAO degrades the norepinephrine and serotonin. Well, we don't want that to happen. We want more norepinephrine and serotonin. So this drug basically helps to stop the MAO enzyme. That's the action of it. Let me give you that information here. So it degrades the norepinephrine and the serotonin. Yes. So that's basically the function of it. The problem is, if you're taking this medication and you have reduced levels of MAO, well, we need MAO. MAO is really important for controlling our blood pressure. So if you take this medication, this would not be given to somebody who has blood pressure problems anyway. But for a typical person who doesn't, you really have to watch your diet, because believe it or not, there are certain foods that tend to increase our blood pressure. And they're foods containing a substance called tyramine. Tyramine increases our blood pressure. And here are some of the foods that commonly have tyramine. Some aged cheeses have tyramine. Bananas, I mean, almost everybody eats bananas. And then some wines have tyramine. So the people that take the MAO inhibitors really have to have very tight dietary control. And there's other foods too. These are just some of the main ones that people eat. So partly because of that reason, these aren't prescribed very often, and they're actually prescribed the least of all antidepressants. Now, some of the tricyclics, if I can step back a minute, one of the ways that those are used today, which is kind of interesting, is for people who have digestive problems because of stress or because of environmental things. So let's say like irritable bowel syndrome, you've probably heard of that, because we know that a lot of our the digestive system, the stomach and the intestines contain a lot of sensory information. And so when you're upset or stressed or depressed, that's why our digestive system is oftentimes affected. And tricyclics has a special property, and I don't know it well enough to explain it to you, that seems to affect that better than the SSRIs. So just kind of an interesting aside. Now, speaking of the SSRIs, the last column here we'll talk about, these are the most commonly used antidepressant medications. The SSRIs, the selective serotonin reuptake inhibitors, the most common ones are Prozac, Zoloft, Celexa, Paxil. These are all medications that you've heard of. They are used most commonly because they have fewer side effects than any of the others. We also have, as a derivation of that, the SNRIs, the selective serotonin and norepinephrine reuptake inhibitors. So it's more broad-based. It's used for both serotonin and norepinephrine. A couple of examples would be Effexor, Zymbalta, Lexapro is an SNRI. And these stop the reuptake of both serotonin and norepinephrine. So they are much more broad-banded here. They do have their side effects. In particular, they can cause problems with sleep. People have to just kind of experiment with them. Sometimes it's better if you take it in the morning, sometimes right before bed, but it can cause some sleep problems for some people. They can cause headaches. And again, they still cause the sexual functioning problems for many people. So it eventually becomes a trade-off. I mean, I hear people talking, I've had clients talk about how they quit taking them because it interfered with their marital relationship or whatever, but it's kind of you have to pick your battles. These medications help with the depression, but there is no medication you can take that's not going to have side effects. I know I've explained to you all before that all medications you take, even an aspirin, is a toxin to your body, and they're all going to have some side effects. Now, one of the biggest concerns with the SSRIs and the SNRIs has been the suicide issue, because back when Prozac, you all were too young to remember this, but back when Prozac was the main antidepressant medication being prescribed, they found that they blamed it on leading some people to commit suicide. So in 2005, the FDA ordered a black box warning on the SSRIs, and this was before the SNRIs, but that's there now, showing that those medications increase the risk in kids and adolescents, and there's an example there. So what I want to explain is what this is about, and this is where I wish I had a chalkboard to to write it out for you. The way that these medications work is that they affect different symptoms at a different time. So these medications tend to affect mood before motivation. Mood before, or is it I'm saying that wrong. Motivation before mood. So what that means is they first start to they affect motivation first, excuse me. So when you're really depressed, you don't have the motivation to even get out of bed or go to work or shower or anything. And sometimes the people who are the most depressed don't have the motivation to even think about harming themselves. But when these medications start to work, the first thing that they work on is motivation. So you've got a person who is still deeply depressed, perhaps thinking about harming themselves, but now has a little bit more get up and go, a little bit more motivation to take the action to harm themselves. So yes, in a way it's the medication, but it's the action of the medication. And this can be mitigated with close monitoring. So what that means is a doctor should never prescribe an antidepressant medication to someone and then just say, here, go take this for a few months, check in if you need anything. They should prescribe the medication, have them come back in 2 to 3 weeks, because that's when the medication is really starting to work. Find out how the person's doing. If it's the sense is that there's a little bit more risk of self-harm, then the doctor can take some action. So there is definitely a way to get around these, and I don't want to leave anybody with the impression that these are terrible medications, because they are life-saving for many people. So here's a silly cartoon to kind of exacerbate that. It's a new antidepressant. Instead of swallowing it, you throw it in anyone who appears to be having a good time. So just very silly. The other biological therapy that we will talk about is ECT, short for electroconvulsive shock treatment. And this one has certainly more controversy around it than even antidepressant medications do. It's the stuff of which horror films are made. If you've ever seen One Flew Over the Cuckoo's Nest, sort of a historical film with Jack Nicholson, a very good film on mental illness and the treatment of mental illness, it's there. It is no longer the scary, dangerous treatment that it used to be. It is a valid treatment that we use for severe depression that has been unresponsive to medication. This is not a first line of treatment for anyone's depression. This is, we've tried everything, all the medications, nothing is working. And this can save people's lives when medications have failed. I have a good video clip of what modern ECT looks like. It's not scary. It's a basic kind of outpatient procedure that I forgot to link to this video. So in the other unrecorded PowerPoint of this chapter that I put on Blackboard, I will link it there. So I think it's worth looking at, or you can just Google your own, what does modern ECT look like? I think it's important just to get a sense of what it does like. So the way this treatment works is that people are given between 70 to 130 volts. It's administered in an outpatient setting by a psychiatrist, by a physician, and they're given generally 6 to 12 treatments over the course of a month. They don't exactly know why it works, but it causes a cascade of neurotransmitter release. That's about the only thing they know. As far as side effects, it's now a very safe, very good alternative treatment for people. It can cause temporary memory loss, not long-term. The modern ECT does not cause long-term memory loss, and it can cause some momentary confusion. So if people can deal with that, it really is life-saving. And then after they go through a course of ECT, if they haven't gotten the results that they wanted, sometimes it's repeated, but then most of the time for people, they just start on a round of antidepressant medication. Oh, sorry about that weird noise. You all will appreciate this. You know how I tend to gesture a lot with my hands. Well, I'm doing that when I'm talking to my computer here, recording this, and I just yanked my headphones off my head. So anything goes. You may hear my dogs barking in this. I'm trying to seclude myself in a quiet room to do this, but be prepared for anything. Okay. Well, let's move on to talk therapy here. This is the last component. Generally, when a person undergoes any kind of biological therapy for depression, whether it's medication or whether it's ECT, the physician or the psychiatrist will recommend talk therapy because there are rarely cases of people who have depression that is purely biological or chemical. You'll hear people talk lots of times about how they have a chemical depression, and that certainly may be true, but there's also other things going on. So just a couple of different types of talk therapies that we can give to people. First of all, interpersonal therapy, which tends to be pretty short term, between 6 to 8 sessions. And these are therapies that focus on problems that people have in their relationships, which is often present in depression. We also talk about things like boundaries, self-esteem, really anything goes as far as relationships are concerned. We also might do behavioral therapy, and what's involved here is really helping people think about that behavioral model where they're displaying depressed symptoms and then people stop reinforcing that. So we need to teach them to display non-depressed symptoms. So that would be social skills training, teaching them things that can reinforce their own behaviors and get reinforcement from other people. And then with cognitive therapy, we just talked about the cognitive model. That basically goes 8 to 12 sessions or so. What we want to do is replace people's irrational beliefs, that's the big little I, with rational beliefs. So those cognitive distortions, those selective abstractions that people say to themselves when things happen, we want to teach them to think more rationally. And it's not thinking positively. Lots of people think, oh, you just have to think positively. No, you're not changing your beliefs with positive thinking, because if, say, you're doing poorly in a class and you tell yourself, oh, everything will be all right, I just need to think positively, that's not helpful. You need to look at the specific irrational beliefs behind it. So it might be thinking, if I don't get an A on every test, I'm going to fail. Well, that's an irrational belief. So that's something that we can deal with. The really great thing about cognitive therapy is we are helping people to kind of go out on their own and operate and function, without the therapist. So what we're doing is teaching people to be their own cognitive therapist. So in the future, if they come across a situation that's stressful and they don't know how to handle it, instead of automatically thinking, oh, this is terrible, I'm doomed, the world is ending, they have learned techniques to replace those irrational beliefs with rational beliefs. So it's a type of therapy that people really carry with them and do well with. Now, one last type of therapy I want to mention here that is really in an experimental phase, but a pretty widespread experimental phase, is the use of psychedelic therapy. And you may be familiar with this or have heard of this. I am not personally using this with my clients, but I think it's going to become more widespread as people understand better how this works. Okay, so it's basically the use of psychedelic therapy to treat several different disorders. Um, it involves the use of MDMA, which is a form of ecstasy, type of ecstasy, which we know is ecstasy, psilocybin, which are mushrooms, psychedelic mushrooms, and they have found that using these psychedelics can lead to significant decreases, particularly in PTSD. It's being used a lot with veterans and with people with PTSD, but also with depression and anxiety. Now this is not they give, oh wow, they'll give you psychedelics and it's going to help my depression. That's not how it works. They don't give you the medication and say peace out, good luck. It's used in conjunction in a therapeutic session. So people are given the medications in therapy, and then they are asked to discuss their feelings, events, other things that might be stressful to them. But they're doing so with this drug-induced sense of openness and warmth. So eventually what happens, and we're still trying to understand this, is that people learn that these memories, these thoughts, these feelings don't necessarily have the powerful hold over them that they used to in the past. So I will be interested to see where this type of therapy goes, how much further, what kinds of things we're going to be able to use it to treat. But it's really interesting the way the therapeutic community is moving. All right, so to wrap up, the last thing I want to tell you here is just a summary here of what we've done, and to tell you that for the typical case of major depression, so your typical person that comes in with major depression, the most effective treatment usually turns out to be a combination of antidepressants and cognitive therapy. The antidepressants sometimes take some working with, because the first one you try, it's a trial and error, doesn't always work for people. So you try a second one, and they find that something like 50% of people have to try more than one before they find one that works for them. Unfortunately, what we see are people will get frustrated that the first one doesn't work and they think, oh, antidepressants aren't working for me. And that's not the case. They may have to try a couple different ones. But over 80% of people are helped eventually by antidepressants, 80% of people who have depression. And then cognitive therapy to work on some of those beliefs that may have led to the depression in the first place. So the combination of the two is the typical treatment for most people with depression.